And as far as I remember, we concluded our last meeting on Wednesday with a discussion about T cells, right? So we talked about the fact that T cells, they originate in the bone marrow, then they mature in thymus, where they become two different populations, CD4 and CD8 cells. And they're different in terms of their function and ability to recognize different types or classes of major histocompatibility complex. Well, CD4 recognize antigens presented by MHC class 2, which MHC class 2 being present on dendritic cells or macrophages or B cells. CD8 cells can recognize antigens presented only by MHC class 1, which is present on all nucleated cells. And then we figure that after the antigen presentation, CD8 cells become cytotoxic lymphocytes, while CD4 cells can become a variety of helper cells, regulatory cells. And we talked about the functions of helper cells. Helper cells, by recognizing MHC class 2 molecules in B cells, they can help B cells to differentiate to plasma cells. Or by recognizing the MHC class 2 molecules in macrophages, they will help macrophages to become more active. Or they can stimulate the maturation and differentiation of CD8 cells, sort of indirectly via production of cytokines and chemokines, and help them to work better. And we figured that, not having a CD4 component like people with human immunodeficiency virus infection have, not having this component is detrimental for the entire immune system because of all these connections that CD4 cells have to other branches of the immunity. Now, what do CD8 cells do? Before, when we discussed innate immunity, we talked about an interesting category of innate immune cells called NK cells, or natural killers, or NK lymphocytes. And I mentioned that they do not phagocytose. Instead, they induce apoptosis. Turns out, CD8 cells do exactly the same. However, remember, NK cell, natural killer cell, doesn't have the ability to recognize cell that's specifically infected with, say, influenza virus or measles, or that is cancerous. They will destroy all abnormal cells across the board. They rather non-specific. Does that make sense? We good? Now, cytotoxic lymphocytes, the product of CD8 cell differentiation, they will attack only those cells, those nucleated cells in the human body that carry the matching antigen as a complex with MHC class 1. Let me explain what I mean by that. Let's say somebody gets infected with the yellow fever virus. And dendritic cells, they present the antigens of yellow fever virus on their surface as a complex with MHC class 1. And they stimulate the formation of cytotoxic lymphocytes that can recognize that specific antigen of yellow fever virus in the complex with MHC class 1. Does that make sense? So these cytotoxic lymphocytes will get into the circulation, and they will circle around, and say one of them finds that antigen of yellow fever virus bound to MHC class 1 on the endothelial cells of blood vessels. CTL will attack these endothelial cells and will destroy them. CTL will not attack any other endothelial cells, any other antigens. Does that make sense? So if there is an adjacent endothelial cells that presents, I don't know, the antigen for Coxsackie virus, that specific cytotoxic lymphocyte will pass by. It recognizes a very specific antigen. Are we clear? Does that make sense? What happens when the recognition occurs? There are two options. Option number one, Fas ligand, Fas receptor interaction. I don't remember what Fas acronym stands for. Basically, you have the lymphocyte and the infected cell, and they have the interaction through the receptor on cytotoxic lymphocyte and the ligand on the infected cell. So they kind of touch each other. That interaction induces apoptosis in the infected cell, and it dies. That's it. Like, it touched the cell died. Does that make sense? Another option, cytotoxic lymphocyte releases molecules called perforins. Perforins form, guess what, pores that perforate the membrane. And then another class of enzymes called granzymes. They enter through the pores into the target cell and initiate apoptosis. Does it make sense? So in both cases, whether it's Fas ligand, Fas receptor interaction, or it's the apoptosis induced by the formation of perforin pores and release of granzymes, in both cases, it leads to the apoptosis of infected cell. There's no eating, no phagocytosis involved. We're good? Does it make sense? So before we move on, I want to do a quick, brief overview with you. Overview of like all immune response together. So we start, we all have intrinsic defenses, like celium, mucus, low pH in vagina or stomach, dermacidins on the skin, lysozyme and mucus secretions. We all have it, and that's the intrinsic component. Sort of physical and chemical barriers. Does it make sense? And then we have innate immunity, which manifests itself through the inflammation. What we have discussed is the migration of white blood cells, predominantly neutrophils and macrophages, from the bloodstream into the tissue. Activation of the complement, which, now that's one of the points of this overview, is for me to show you the link between the innate and adaptive immunity. So complement activation may be caused by lectin-mannose interaction, lectin pathway, activation by molecules, different molecules on the surface of the pathogen, the alternative pathway, or complement can be activated by, doesn't say here, but antibodies can activate complement, right? So that's link. That makes sense. That's the link, right? Interference can be produced as the element of the innate immune responses. But as you remember, all the innate responses are rather non-specific and sort of weak, limited. And then you have adaptive immunity. The humoral component, which is mediated by B cells that, when differentiated into plasma cells, produce antibodies. Right? Now, antibodies, remember what can antibodies do? They can tag. They don't really kill, but they tag. And by that tagging, they either activate complement, there you go, or tagging is opsonization of a pathogen. Opsonized pathogens are really easily recognized by macrophages. So it's a link number 2. Does that make sense? And you have a cellular branch, which involves T cells, which can become cytotoxic lymphocytes. It's pretty straightforward. They just kill, pathogens. Not pathogens, sorry, infected cells by inducing apoptosis in them. Or T cells can become helper cells. And helper cells can stimulate macrophages. They can stimulate B cells. Okay, so that's another link between adaptive and innate and cellular and humoral immunity. So you have to appreciate that these responses, they are not independent. And by affecting one, you essentially are affecting another. So if you say, oh, I'm going to get rid of the macrophages, it's going to be fine. No, it's not going to be fine. Because it's going to affect the process of inflammation. It's going to affect the responses of humoral immunity. Antibodies by themselves don't do much. Antibodies, when they tag the pathogen, they need macrophages to destroy that pathogen. Does that make sense? It's really important. We're good. How about we talk about vaccines? Now, let me put it, so I will try to keep myself limited. I can bitch about this for a really long time. Okay, but I will give you a quick overview of the vaccines as what kinds of vaccines are there. I will probably pause this and we'll play a little game. Not that I'm hesitant to record it, we'll just easier not to record. Okay. So generally, the vaccines can be divided into several categories. First and foremost, whole cell vaccines, which means you take a pathogen and use it as the vaccine. Okay? There are two ways. Option 1, you take a pathogen and inactivate it. Does that make sense? Okay? And then you administer this inactive pathogen to a patient. Patient is exposed to all the antigens. Ideally, patient develops the immunity without the infection. Do you understand what I'm saying? Because there's no living, nothing really lives there. Does that make sense? And the patient has an immunity. Should work perfectly. It doesn't. But, the vaccine that you get, the inactivated vaccine, most classic is inactivated polio vaccine. Okay. Attenuated, which means you have a pathogen that is weak, that does not cause disease or causes a mild form of this disease. Okay? So you don't die, kind of, maybe you'll get sick a little bit. Okay? Measles, mumps, rubella. That's live attenuated viruses that wouldn't kill you, and you're going to get good immunity. Okay? Probably the first vaccine, the one that Edward Jenner developed in 1796, the smallpox vaccine, he used a different pathogen. He used a cowpox. Well, it was actually not cowpox, it was horsepox. A few years ago, they actually figured it out. It wasn't. Everybody thought it was coming from the cows, but it was actually coming from horses. And he used horsepox, and this horsepox didn't kill anyone, but provided a pretty good immunity. Does that make sense? And that's wholesale. So you may have dead pathogen or live but weak. And there are subunit vaccines. So take a piece of a pathogen, you take an antigen, an individual antigen, okay, and you stick it into someone. And the person develops the immune response to that particular antigen. Hepatitis B people, that's vaccine. I'm not saying that you are people with hepatitis B, don't get me wrong. Hepatitis B is subunit vaccine. Extraordinarily safe. Just one protein of the virus. Extraordinarily safe, extraordinarily effective, pricey. Okay. HPV, human papillomavirus vaccine, also known as Gardasil. Okay. It's basically a subunit vaccine. Several subunits are assembled together. The most frequent side effects of this vaccine, anyone knows? Pain in the site of injection. Duh. And there are vector vaccines, which works in a fascinating way. So you take a virus, for instance, a virus. Okay, viruses are easier to manipulate. Take a virus, and you take genes from whatever you want to vaccinate against. Stick it into the virus. And let it out. The advantage, easy to manipulate. Virus reproduces in the vaccinated person. Virus is safe. You take something that doesn't cause any disease, and it constantly produces the antigen. And it's often safer to work with this type of approaches. Let's say Ebola virus. Working with Ebola virus in the lab is extremely hard and dangerous. What you can do instead, you can take one gene from Ebola virus, stick it into another virus, okay, which is safe and easy to manipulate. And then you can use that chimera, that sort of combination, okay, and stick it into people, and people will produce immune response to Ebola. That's actually how a vaccine against Ebola was made in 2015. That's what they used experimentally in Africa. And it proved to be safe, at least, and what we saw, it was effective. Okay? So, sort of a take-home message from this. I give you a description. You recognize the type. Good? Go ahead. Currently in use. Okay. There is, I don't know how widely it is used. So we have an extremely good vaccine against yellow fever virus. It's called 17D. So if you decide to go on a trip to Africa or South America, go and get it. I was vaccinated. It's super effective, super safe. Okay. So what now? There's a company, if they didn't get bought, called Cambus. What they do, they take this vaccine, gut it, so take some genes of yellow fever virus, throw them away. Put the genes for dengue virus instead. Viruses are very similar, so it works. What you get in the end, you get a chimera. You get a virus that has some genes from dengue, some genes from yellow fever. when you put it into people, it reproduces, doesn't cause any disease, and produces immunity against dengue. Does that make sense? Did I give a good example? The problem with vectors, when we develop vaccines, it's still hit and miss. A lot of it is by chance. You know, everything says, oh, that's going to be a great vaccine. And then it becomes a huge flop. The greatest example of this is HIV. We tried everything. I'm not kidding, everything. And so far, all vaccine approaches. And so far, we have no vaccine against HIV whatsoever. Okay? Questions? So with this, we are moving to other clinically relevant issues with immunity. And the first one is the ailment that affects a lot of people, including, for instance, me. And then who else has allergies? Okay. Yeah. I have my own cats, mainly. Dust. Okay. Pretty bad allergy. So the mechanism, it is called hypersensitivity, when your immune system doesn't work the way it is supposed to. Allergy belongs to type 1 hypersensitivity, which is also immediate hypersensitivity. And it may, you know, the mechanism is pretty fascinating. First of all, you don't have allergy. Usually, you don't have it. Like, I didn't have the cat allergy till 1988. I developed it specifically in 1980. So what happens? What happened to me probably? I got exposed to some antigen. Did I get in contact with cats before? Oh yeah, on multiple occasions. I love cats. I can't touch them, but I love cats. Okay? So at some point, some unlucky moment, I get exposed to some kind of cat-associated common antigen. In this antigen, right here, stimulated the clone of B cells that started to produce immunoglobulin E. I mean, they differentiated into plasma cells and started to produce immunoglobulin E. This moment called sensitization. I become sensitive. Does that make sense? So immunoglobulin E, that was produced at the time, bound to mast cells in my tissues. Do you follow me so far? Nothing happened. Nothing happened at this particular moment. I was totally fine. And then I found another cat and I started to pet this cat. And I got exposed to the same antigen second time. This time, this antigen bound to immunoglobulin E that was sitting on the surface of my mast cells. This binding caused the degranulation of mast cells and release of histamine into my bloodstream. And I got runny nose, itchy eyes, constriction of the bronchi, inflammation of bronchi, bronchitis, and that happens every time when I contact a cat. From now on, I'm not kidding. I sometimes, in some cases, depends on the type of a cat. Sometimes I can walk in the house. I do not have to see a cat. I can say this house has a cat. Bye bye. I'm about to leave, unless I get my antihistamine. We have friends. My son and I would take whatever Zyrtec, whatever we have at hand. We take it an hour before we visit them. So otherwise, we're going to be miserable. We do not pet cat, nothing. No, just being in the same room. Does that make sense? So it's IgE-mediated response, which actually brings us to the very interesting topic. So, to the very interesting topic of what you can do about allergy. What you can do about allergy? Can you tough it out? So basically, if I would want to get rid of that allergy, I would need to get a cat and vigorously pet it for several weeks. I would be devastated the entire time physically. I would probably have constant asthma attacks and no antihistamines, like just to keep myself controlled as much as I can, because that will lead to degranulation of all Ig-bound mast cells, and they're gone, and I'm free. I'm good. I'm clear. Okay, and as long as I will keep the cat, I would be fine. Do I want to go through this? Absolutely not. So I will keep my allergy. This procedure, of course, can be stretched out. Desensitization procedures can last from 2 to 5 years, which, if you think about, cost and time, maybe it's just easier to have a pack of antihistamine in your back pocket, sort of. Okay, and for those with asthma, like my son, the breathalyzer, not the inhaler. The inhaler, breathalyzer is different. Yes, the inhaler. Okay, does that make sense? That's it. Now, to the topic of the scourge that damages the lives of many kids in the United States, peanut butter allergy. It can be absolutely terrible. If kid is extremely sensitive to peanut butter, it may cause anaphylactic shock, which means massive degranulation of mast cells all over the body, massive vasodilation, which leads to the drop in the blood pressure, which is vascular shock, and constriction of the blood vessels, constrictions of the bronchioles, which is anaphylaxis. So altogether, anaphylactic shock. What can you do about it? You can abstain from peanuts, which is really hard and sometimes gets to the pretty funny situations. My friend was politely asked to put his packet of peanuts on the Delta flight back into his bag, because the flight attendant was afraid that he's going to drop a peanut on the floor and it will cause allergic reaction in another passenger. The likelihood of it is really small, but in extremely severe patients, it can happen. What you can do about it else from abstaining? There's a therapy when people with peanut butter allergy receive peanut butter. Basically like injections. Well, not injections of peanut butter, don't get me wrong, like the protein. So what happens, these injections do not cure the allergy completely, no. But let's say kids do not have to sit at a separate table. They can't eat peanut butter, but they can sit with kids that have PBJ sandwich. Does that make sense? There's even better option, sort of prophylactic option. When women are pregnant, they should just eat peanut butter. There was a massive study in Israel that showed, one of the best, there are several, but there's one of the best studies, it was done in Israel. They showed that women that consumed peanut butter during pregnancy had like 1% of kids showed some allergy to peanut butter, or even less. Moms that completely abstained of peanut butter during pregnancy, their children, a lot of them were allergic, like 45%. There's an enormous difference, orders of magnitude difference. So all in all, basically, when you're pregnant and people tell you, oh, don't eat strawberries, your kid's going to be allergic to strawberries. It's the other way around. Eat strawberries, and probably your kid is not going to be allergic to strawberries. I mean, again, reasonably. When my wife was pregnant, after 3 liters of tomato juice, I politely told her that's enough. Like in one sitting, So she just wanted it. Okay. Now, again, reason. Go ahead. Basically, what they do when they desensitize, oh, you mean like expose the fetus before? Probably, yeah. But I think the idea is that the protein is going to be processed by mother's digestive system into the whatever chunks they are. Does that make sense? So maybe that's the point, sort of a more natural way. Okay. Probably they can. Now, type 2 hypersensitivity. This one is not as immediate as allergy, but it also develops pretty rapidly. And this one is mediated by immunoglobulin G. So 2 pathologies associated with type 2 hypersensitivities are transfusion reactions and rhesus conflict. Question? So, transfusion reaction. In 1912, Karl Landsteiner discovered the blood groups. Before that, there were attempts to, well, think about this. Attempts to transfuse blood from person to person sound pretty reasonable, right? Well, there were animals that were tried as donors, like baboons and pigs. You can imagine that it didn't work terribly well either for a pig or for a patient. You know, they both died of different reasons. Basically, we have 4 major groups, blood groups. A, B, AB, and 0. A and B refer to the antigens on the surface of the red blood cells. A group has A, B group has B, AB, no antigens in group O. So far, do you follow? If a person has a certain antigen, then this person doesn't have intrinsic antibodies against this antigen. So a person with the blood group A doesn't have antibodies against A. We all have antibodies against the surface antigen, the blood group antigens. Does that make sense? Do you understand what I'm saying? Okay? So this antigens called agglutinogens. Antibodies are called agglutinins. So say I am type O, which means I have no antigens, but I have both antibodies. Do I make sense? Anyone with AB group that anybody knows? No? AB. Anyway, if I would have the group AB, I have both antigens on the surface of my red blood cells, but I have no antibodies. Why it's important? If my antibodies encounter antigens on the red blood cells, they start to agglutinate them, to put them together. So say the AB blood group, see AB? If you will mix red blood cells with antibodies against A, your blood will start to form clumps. Does that make sense? If you mix it with antibodies against B, your blood will start to form clumps, red blood cells. This is called agglutination. So now, let's say you have a patient like me. You have me, okay? I'm type O. And you decide to transfuse blood from a person who has type A. Do I have antibodies? I'm type O. Antibodies. Do I have I do have antibodies, right? So if I receive this, my antibodies against A, what they're going to do with these red blood cells? Are they going to bind my antibodies against A? Are they going to interact with A? Sure thing, that's what they're for. That makes sense? So, my anti-A antibodies will bind to these red blood cells, form clumps. What's going to happen to me? I'm going to feel really, really bad. Does that make sense? Because those red blood cells that are transfused into me, because usually it's a red blood cell transfusion, those red blood cells that get into my system, they all get agglutinated by my anti-A antibodies. What if you decide to transfuse group B? Do I have anti-B antibodies? I'm type O. Yes. This red blood cell is getting clamped. Yes. So basically, I cannot receive any of these blood groups except mine. Type O can receive only type O. But I can be a donor for everybody. Well, me personally, not for everybody. I'll tell you a little bit later. But based on the main blood groups, yeah, I'm a universal donor. I can give my type O blood to anyone. Does it make sense? Whether you have antibodies, whether you have those agglutinants or not, you can receive type O blood. Does it make sense? Now think about type AB. This one. Do they have antibodies? Type AB. Do they have antigens on the surface of the cell? They do. Which means if there are antigens, there are no antibodies. Does that make sense? No antibodies. Which means type AB can do what? Receive anything. They are universal recipients. Does that make sense? So a person with type A blood, what can this person receive? Type A or O. Does that make sense? You can always receive the same blood type. Does it make sense? So that's now how many known blood groups there are. As far as I know, 52. I'm talking about like 52 different antigens that can determine different blood groups. We don't use all of them because these groups are critical. Does that make sense? Type O actually is the most common. Okay. So far, does that make sense? And you have to understand, let's say I am type O. I have no agglutinogens, no antigens on the surface of my red blood cells. But I do have antibodies, and I have them from the moment I was born. They developed in me, in me. I do not need any exposure. They in me from the moment of birth, or before that, when I was developing, when I was a mere fetus. Okay? Does that make sense? Now, there's another antigen that is called rhesus factor. Okay? So, rhesus factor, or D antigen. I have it here now. D antigen, or rhesus factor. It's a protein on the surface of red blood cells that has nothing to do with A, B blood types. So, listen, I'm going to use myself as an example because it's easy. I am type O. I have neither A nor B antigen. But I'm type O positive. So I have rhesus factor on my red blood cells. Does it make sense? The difference is that I do not have any antibodies against rhesus factor. We don't form them. Does that make sense? Who can form anti-rhesus antibodies? Anti-rhesus antibodies can be formed by rhesus negative people when they accidentally receive rhesus positive blood. Do I make sense or not? So I want to use someone as an example. I'm going to use Nicole. It's fine. No, you don't have to put it away. Just so imagine there is a need for transfusion. I'm type O, so I'm a universal donor. Does that make sense? So no matter which AB blood type you are, you can receive my blood. Does that make sense? However, we need to make sure that since I'm rhesus positive, you are rhesus positive too. Because if you rhesus negative, you will receive my blood and you will produce antibodies to my rhesus factor. Does it make sense? First time, if that happens, you rhesus negative, I'm rhesus positive, you receive my blood, you produce antibodies. First time, probably nothing severe is going to happen. But if you happen to receive another dose of rhesus positive blood, you already have antibodies. They will attack those red blood cells and they will destroy them. Does that make sense? Do you understand that? So that's why people who are rhesus negative should receive rhesus negative blood. People who are rhesus positive can receive either one, it doesn't really matter. Do you follow me so far? So that brings us to the condition known as hemolytic disease of newborns, or erythroblastosis fetalis. Follow me in this journey. This is mom, and she's rhesus negative, so she doesn't have rhesus factor. Does that make sense? And this is baby. Baby is rhesus positive. So baby has rhesus factor on its red blood cells. You can see rhesus factor as those triangles. How could it happen? How could mom have no rhesus factor and baby has one? Huh? Father was rhesus positive. Okay. So parents, mom was rhesus negative, father was rhesus positive. That's the first pregnancy that I show you here. Is baby at danger? Nope. Baby's fine. You don't have to do anything technically. It's because mom blood and baby's blood, they're completely isolated from each other by placenta. They do not get in contact through the entire pregnancy. We're clear? Pregnancy. What is the culminating moment? What happens at the end? Birth, delivery. During the delivery, when placenta detaches, there is a little exposure of mother to baby's blood. So a little bit of baby's blood enters into the mother's circulation. And remember, baby's red blood cells, they are rhesus positive. So mother's immune system starts to produce antibodies against rhesus factor. Where is baby at this point? Yeah, happily in the cradle probably. Baby's fine. Baby's born. It's all good. Does that make sense? And then this family decides to have another baby. Remember, father is rhesus positive, mom is rhesus negative. So mom is still rhesus negative. She doesn't have rhesus factor. She has antibodies. That's a different story. And she's pregnant with a second rhesus positive baby. And she has immunoglobulin G that can attack rhesus positive red blood cells. What is the unique feature of immunoglobulin G? What can it cross? why there is no barrier for immunoglobulin G, mother's immunoglobulin G. Immunoglobulin G, mom, where does it circulate? In which fluid? Nothing too fancy. Which fluid? Blood. Yeah, it's in the blood. So what does it cross? From the mom's blood to baby's blood, what does it have to cross? Placenta. That's immunoglobulin G. They can do it. So that immunoglobulin G crosses placenta, enters baby blood, and finds there red blood cells that have rhesus factor in them. And what happens to those poor red blood cells? They start to form clumps. So you have basically a transfusion reaction in the fetus. And this is why it's called erythroblastosis fetalis. Does it make sense? Now, that's horrible. Any transfusion reaction, any clumping of red blood cells leads to hypoxia, first and foremost, right? Because you don't have enough red blood cells. It leads to, potentially may lead to the damage of the blood vessels. It may lead to the kidney failure, because if red blood cells are destroyed, then heme and iron, they toxic for kidneys. They kill kidneys. Does that make sense? So, adult with transfusion reaction, oh, it's terrible. It's really hard to, you know, it's a bad thing to have. The fetus with transfusion reaction, no, that's even worse. So that usually C-section has to be performed, and you know, some ICU, you know, for whatever age the fetus is. It's really bad. Okay, can you prevent it? Those of you who went through this ordeal, and I had several students who had rhesus conflict, students who were rhesus negative and babies were rhesus positive, they know by their own experience about the existence of raw gamma antibodies. So what they do, and I think it's incredibly elegant. Raw gamma antibodies are antibodies against the rhesus factor. Woman receives the shot, raw gamma antibodies. When delivery happens and baby's red blood cells enter the circulation, woman already has antibodies to red blood cells. Do you understand what I'm saying? Those antibodies that are there just sitting in the blood, the ones that come from the syringe, they bind to the baby's red blood cells and completely block them. So mother's immune system doesn't recognize them. It doesn't see them. Do you understand what I'm saying? They work like those antibodies work like an invisibility cloak for rhesus antigens. And yes, if there is a rhesus conflict, woman has to receive the raw gamma shot every time there is a rhesus conflict. And it works great. It prevents rhesus conflict, prevents the erythroblastosis fetalis. That makes sense? The mechanism of raw gamma antibodies. Good? Now we're going to take a break now. There's those separate, and when we'll come back, we'll go over the quiz actually first.